Normal does not always mean safe. You check your blood pressure. It reads 128/82. Your doctor says it is within the normal range. You feel reassured. But here is the uncomfortable truth. A stroke does not require extreme hypertension. It requires vascular vulnerability. Blood pressure is a measurement. Stroke risk is a process. The number on the cuff reflects pressure at a single moment in time. It does not measure arterial stiffness. It does not measure endothelial damage. It does not measure plaque instability. It does not measure microvascular fragility in the brain. This is where the misunderstanding begins. Cerebral blood vessels are delicate. They are designed to handle rhythmic pulsatile flow. When arteries gradually stiffen, even a normal pressure reading can translate into higher pulsatile force at the microvascular level. As arteries lose elasticity, pulse pressure increases. The systolic number may remain technically normal, but the mechanical energy transmitted into the brain's small vessels increases. Over time, this repeated mechanical stress damages the endothelial lining. Micro tears form. Inflammatory signaling increases. Small vessel remodeling begins. You do not feel this happening. There is no warning sensation when endothelial function declines. There is no pain when vascular stiffness increases. A person can have a blood pressure categorized as normal and still experience chronic vascular strain. Another factor is variability. Blood pressure fluctuates throughout the day. Stress, poor sleep, insulin spikes, caffeine, all cause temporary elevations. If the average reading appears normal but daily peaks are frequent, vascular stress accumulates. Stroke risk is not determined by a single clinic reading. It is determined by long-term vascular biology. The hidden role of arterial stiffness when we talk about blood pressure, we usually focus on the numbers: systolic, diastolic, normal, elevated, high. But those numbers do not fully describe how force is being delivered to the brain. Arteries are meant to expand with each heartbeat and recoil smoothly. This elasticity absorbs mechanical energy. It protects delicate microvessels and organs such as the brain. When arteries stiffen, that buffering capacity weakens. Even if your resting blood pressure reads within the normal range, the pulse wave travels faster through stiff arteries. The reflected wave returns earlier. This increases pulsatile load in cerebral circulation. In practical terms, the brain's small vessels are exposed to sharper pressure peaks. Over time, repeated pulsatile stress damages the endothelial lining. Nitric oxide production declines. Vascular tone becomes dysregulated. Small vessel walls thicken and lose flexibility. This process is gradual. It often begins in the 30s or 40s. You may feel healthy. You may exercise regularly. Your blood pressure reading may not cross the hypertension threshold. But if arterial stiffness is progressing, stroke risk can increase independently of average blood pressure. There is also a microvascular component. Small vessel disease develops when chronic mechanical stress disrupts autoregulation. The brain normally adjusts vessel diameter to maintain stable perfusion. When endothelial function declines, this autoregulatory capacity weakens. That makes the brain more vulnerable to both ischemic events and hemorrhagic events. What is important to understand is this: stroke risk is not only about how high pressure rises. It is about how that pressure is distributed and absorbed within the vascular system. The metabolic drivers behind normal readings here is where things become more complex. Blood pressure can look normal on paper while metabolic stress continues quietly in the background. Insulin resistance is one of the most underestimated contributors to stroke risk. When insulin levels remain chronically elevated, even without overt diabetes, several vascular changes occur. Endothelial nitric oxide production declines. Arteries become less responsive to relaxation signals. Inflammatory cytokines increase. This creates a pro-inflammatory vascular environment. Chronic low-grade inflammation promotes plaque formation in larger arteries and microvascular damage in smaller vessels. Plaques do not need to cause severe blockage to be dangerous. They only need to become unstable. An unstable plaque can rupture suddenly. When it does, a clot can form and travel to cerebral circulation. This is a common mechanism of ischemic stroke. What makes this particularly concerning is that insulin resistance can exist for years before glucose levels rise enough to trigger concern. You may not be diagnosed with diabetes. You may not be told you have hypertension, yet endothelial dysfunction may already be progressing. There is also the role of triglycerides and small, dense LDL particles. These particles penetrate the arterial wall more easily. They increase oxidative stress and promote plaque instability. Cortisol adds another layer. Chronic stress increases sympathetic tone and impairs vascular repair mechanisms. Even if resting blood pressure is normal, episodic surges can strain vulnerable vessels. When metabolic dysfunction, inflammation, and arterial stiffness intersect, stroke risk becomes more about vascular integrity than about a single pressure number. The danger of variability in nighttime patterns. A single blood pressure reading is a snapshot. Stroke risk is influenced by pattern. Blood pressure naturally fluctuates throughout the day. It rises during stress. It increases after high sodium or high carbohydrate meals. It responds to poor sleep and emotional strain. In healthy physiology, blood pressure declines at night. This is known as nocturnal dip. During deep sleep, sympathetic activity decreases and parasympathetic tone rises. Vessels relax. The brain receives stable perfusion at lower pressure. When this dipping pattern is reduced or absent, vascular strain continues around the clock. Non-dipping blood pressure patterns are strongly associated with higher stroke risk, even when daytime readings appear normal. There is also the issue of variability. Large swings in pressure, even within the normal range, can stress cerebral microvessels. Repeated fluctuations create shear stress on the endothelial lining. Over time, this weakens vessel integrity. Imagine bending a small metal wire repeatedly. It may not break immediately, but repeated stress gradually compromises structure. The same principle applies to cerebral arteries. Individuals with high blood pressure variability often have underlying autonomic imbalance. Elevated sympathetic tone during the day and insufficient parasympathetic recovery at night create unstable hemodynamics. Sleep apnea is another contributor. Repeated oxygen drops during sleep trigger sympathetic surges and transient blood pressure spikes. These episodes may not be reflected in a routine clinic measurement. This means someone can present with acceptable daytime numbers while experiencing significant nighttime vascular stress. Stroke risk is influenced by long-term hemodynamic exposure, not just clinic averages beyond a normal toward true vascular protection. If normal blood pressure does not guarantee safety, the question becomes practical. What actually reduces stroke risk? The answer begins with shifting focus from isolated numbers to vascular quality. First, arterial flexibility matters. Regular aerobic training improves endothelial nitric oxide production and reduces arterial stiffness. Resistance training improves insulin sensitivity and lowers baseline sympathetic tone. Together, these adaptations reduce pulsatile stress reaching the brain. Second, metabolic stability is critical. Improving insulin sensitivity reduces chronic inflammation and lowers the likelihood of plaque instability. Stable glucose patterns reduce oxidative stress within the arterial wall. This strengthens vascular integrity over time. Third, sleep must be treated as a cardiovascular intervention. Restoring deep sleep supports nocturnal blood pressure dipping. It lowers evening cortisol and reduces nighttime sympathetic activation. Consistent sleep patterns stabilize hemodynamics across the 24-hour cycle. Fourth, monitor patterns rather than relying solely on single readings. Home blood pressure monitoring over several days can reveal variability. In some cases, ambulatory monitoring can detect abnormal nighttime patterns that clinic readings miss. Finally, address chronic stress load. Reducing persistent sympathetic activation improves vascular tone regulation and lowers sudden pressure surges that strain vulnerable vessels. The key insight is this: stroke risk is determined less by whether your blood pressure is labeled normal and more by the condition of your vascular system. Elastic arteries, stable metabolism, controlled inflammation, restorative sleep. A normal reading is reassuring, but true protection comes from preserving vascular function long before numbers become abnormal.